Hi, everyone. My name is Matt Fields, and I am the ultrasound section director for the Department of Emergency Medicine here at Jefferson. Today, I'm going to talk to you about the EFAS exam, which is hopefully something that's not new to most of you, but is something that's always good for us to review. And I'm hoping I can throw in a few tips and tricks for those of you that are already pretty skilled at this exam. So let's go ahead and jump into it. All right, so as we all know, the golden hour of trauma is important to rule in all the life-threatening pathologies as quickly as we can and get patients to the operating room. In one study, it was found that the time to laparotomy for intra-abdominal bleeding from trauma affects survival for delays of up to 90 minutes. So they found in this study that the mortality increased by 0.35% for each minute delay in ruling in significant intra-abdominal bleeding. The history of ultrasound, or the history of the EFAS exam, starts going back to the early days when we did this procedure known as the diagnostic peritoneal lavage, or DPL. And this procedure had a lot of issues with it, a lot of limitations. For those of you who have done one of these or seen one of these, I think I saw a couple in my residency, but since then fortunately haven't seen too many of it. But it's invasive and it can even introduce bleeding, can cause other injuries. So starting in the 70s, we actually here at Jefferson got the first study that showed that you could see free fluid in the abdomen using the amplitude mode of ultrasound. Just they took cadavers and they kind of put fluid in the belly and rolled them around and showed that this changed based on position. In the 80s, Germany and Japan really started to look at this in trauma patients and diagnosing splenic injuries by using ultrasound. In the 90s, a lot of this literature made its way to the United States and was adopted quickly, and it was realized this could be formalized into a protocol. I believe as a female trauma surgeon, Grace Ruzicki was the first person to coin the term FAST exam in 1993, which stood for the focused abdominal sonography for trauma. In the 2000s, we realized that we could also add on lung ultrasound. Dr. Lichtenstein out of France was an intensivist who really kind of pioneered this work, showing that we could rule in pneumothorax as well. And so it was realized we could amend the previous FAST exam to be the extended FAST exam, but now we called it the focused assessment with sonography for trauma because it's not just the abdomen we're looking at. And in the present last couple of decades, this has become, a standard of care, part of ATLS, and part of the AIUM recommendations for care and trauma. In one randomized clinical trial, they actually randomized ultrasound versus non-ultrasound in the trauma patient. And this study enrolled 262 patients, and they found that the arm that had ultrasound first, the EFAS exam, led to a decrease time of 64% to get the operating room and reduced length of stay overall by 27%. And now we see the EFAS is utilized again throughout the world, 95% of trauma centers in the US and worldwide. This person right here in this photo was one of my mentors from my residency at Penn, John Pryor, who was the trauma surgeon there, just a wonderful teacher and somebody who unfortunately lost his life in service to his country during the war with Afghanistan. So, but just a great guy. So when do we use the FAST exam? Well, we use it pretty much for any blunt trauma, and we also use it for penetrating trauma. We can use pretty much any probe. The phased array in the middle, or also sometimes people call the cardiac probe, people like a lot because it is smaller and can get in between the rib spaces. But the curvilinear probe is useful as well. We'll pull out the linear probe when we look at the lungs and want to evaluate lung sliding. So positioning, what not to do. So here we see somebody trying to do a FAST exam while multiple other procedures are going on. You can see they're standing on the patient's left, which is not the ideal place to be ultrasounding. Their hand is totally the opposite direction of the way they're looking. And so they're trying to look at the screen, but also manipulate the probe. And so we fast forwarded this, you can see how long it's taking just to try and get one cardiac view. So this is not what you want to do when you're trying to do a FAST exam. You want to make sure that you position yourself well for success. You want to be ideally on the patient's right. You want to use good probe technique by holding the probe with 2 fingers and actually using these other 2 fingers to try and make contact with the patient's skin, and that anchors you and prevents you from sliding around. And here we can see that using small motions to kind of fan and see that right upper quadrant. Then we move over to the left upper quadrant and ideally visualize the kidney and spleen there. And we're going to go through these a little bit more slowly. This is just showing a quick run through of all the different views. We then can go down to the bladder view. Scan through the bladder view in 2 planes. And then the subxiphoid view. The order really doesn't matter here, whatever you prefer. Some people like to just go right upper quadrant, then cardiac, then left upper quadrant. Totally fine as long as you're systematic. So there's 4 questions we're really asking ourselves, and it's important to think about the FAST exam in terms of the clinical questions we're asking. We're asking, is there peritoneal free fluid? So that's abdominal free fluid. Is there pericardial free fluid? Is there pleural free fluid? And is there collapse of the lung? Those are the 4 questions. And you really should break down those questions in your head when you're doing the FAST exam. Otherwise, you may miss something. So this can be broken down into hemoperitoneum, hemopericardium, pneumothorax, and hemothorax. So the first question, hemoperitoneum, we're going to answer that question by the 3 major views of the abdominal part of the FAST exam. And that's the right upper quadrant, the left upper quadrant, and the bladder view. Jumping into the right upper quadrant, these are our anatomic landmarks, and we can kind of either look at this by placing the probe more anteriorly or way over to the mid-axillary line, as you see in this image on the upper left here. And our anatomy is shown on this image on the right, where we see that bright echogenic line going across the screen left and kind of going downward is the diaphragm. Above that is the lung, or to the left that is the lung. We see the big liver there. The liver is a point of reference for ultrasound. We kind of often refer to things as to whether they're hypoechoic or hyperechoic, and that's in reference usually to the liver. The kidney is below the liver there, and that space in between the liver and the kidney is Morrison's pouch, and that's a key location for looking at the right upper quadrant. So this is an example of a positive FAST exam where we see free fluid in Morrison's pouch, and you can see that fluid is black and it's sharp and pointy, and that's a characteristic of free fluid. Here's a clip showing just a simple positive right upper quadrant. Hopefully this is an image that you burn into your mind and you recognize quickly in the trauma setting. Now, it's actually been studied a little bit, and it turns out that if you want to increase your sensitivity for the FAST exam, you should look at the caudal edge of the liver. Sometimes that's where fluid shows up the first. So really make sure you look at Morrison's, but also sweep down and look at that caudal edge of the liver. So there's that liver edge, and there's the free fluid we see there. I had a case of this the other day that I just added to you real quick, where you kind of actually look at Morrison's, it's totally clean, but then you look right there and you see that free fluid hiding out down there, just below the kidney, right at that kind of lower edge of the liver. Highlighted there for you. Sorry, the image was a little shaky. Took it on my iPhone. All right, another way to increase your sensitivity is actually just if you have the patient go into Trendelenburg. We don't often do this in the trauma bay, but it's something that if you really have a high index of suspicion, you really want to make sure you increase your sensitivity. That'll cause the fluid to basically pull towards gravity and go into that space. The next view is the left upper quadrant, and this is often the hardest view to obtain because the spleen is so small and you don't get a good, what we call sonographic window to shine through. So you really sometimes need to get your hand all the way around and almost where your knuckles are touching the stretcher. And sometimes you have to kind of slide up and down to get the full view of the kidney. Sometimes in the left upper quadrant, you'll get fluid going above the spleen, and that's just because the spleen is not so strongly adhered to the diaphragm. It doesn't have as much pressure there that allows for that potential space. So again, in the right upper quadrant, it tends to go in Morrison's pouch, which is the hepatorenal space. On the left upper quadrant, you might see it more subphrenically. And another thing to think about when you're looking at the left upper quadrant, a lot of injuries in the abdomen are splenic hematomas and splenic injuries. And if they're encapsulated, you may not actually see them, but sometimes you will, and that can be like a hyperechoic appearance of the spleen. And one thing we always remember is that when we're doing the FAST exam, we're never truly we're not usually identifying the injury itself. We're usually looking for the secondary sign, which is the free fluid in the abdomen or the hemoperitoneum. Going down to the bladder. So you're going to usually sweep through this in two planes, in transverse and then sagittal. And the appearance obviously is going to differ between men and women. Men, you'll see sometimes the seminal vesicles and the prostate, and then women, you may see the lower uterus or the cervix. When you rotate the probe 90 degrees, this will be the image you'll see. So the left, left side of the image is towards the head, and the right side of the image is towards the feet, and we see the bladder with the prostate behind it. Or in the case of a female, you'll see sometimes the uterus kind of cradling the bladder like this, if the uterus is anteverted. Free fluid will typically appear like this. It'll follow the peritoneal reflection and kind of wrap around. And sometimes that's called the double bladder sign. One pitfall is if you try to scan the patient after a Foley's been placed and the bladder's decompressed, sometimes this can look like the bladder itself. So you got to be aware of that. If you see anything floating within the sac of fluid you're looking at, then that suggests that it could be free fluid, because the bladder shouldn't have anything floating in it. Whereas if you have hemoperitoneum, you'll have bowel floating. One thing you got to be careful of whenever you do the transverse approach. So this is a sagittal image, but I'm going to show you what happens if you do a transverse approach and you take too steep of an angle, is you can actually, the beam of your ultrasound can go like this and totally miss the free fluid. So it's really important that you always try to like slide down and go straight over, as low down as you can over the pelvic brim, to make sure you go through the free fluid. Alternatively, if you make sure you just do a sagittal view, you'll avoid this pitfall. Other things, yeah, scan low. Be careful of the image being overgained. Sometimes you see how the image is the free fluid looks pretty white. That's because whenever you go through fluid, you cause this artifact to occur called posterior acoustic enhancement, which everything behind it looks more white and washed out. So that can happen if you have too much gain. And again, scan before the Foley. And again, if you opposite of the right upper quadrant, here reverse Trendelenburg will improve sensitivity. All right, so how much fluid do you need to detect? Or do you need to be there before you'll have a positive FAST exam? Really, you need about 600 milliliters of fluid, and that was when you really start to reliably detect it on ultrasound. So if you can think about it, that means that if you're early in the bleeding, the FAST exam may be falsely negative. And we know that from studies that the FAST exam has a sensitivity of somewhere in the 60 to 80%, but the specificity is high. If there's going to be bleeding in the free fluid, you're going to see it. It's not 100% specific, because you can have ascites and other things that can be a fake out. But for the most part, in the right clinical scenario, it is a great rule and test. And it's found to be typically 100% sensitive for patients needing laparotomy, because you don't usually have, if it's the bleeding so slow, usually they may not have to go to the OR. Again, you can improve your sensitivity with positioning. And in one study, they found serial exams improve sensitivity from 69 to 85%. So something to always keep in mind. So moving on to hemothorax. So I mentioned this next because this is actually information that you actually obtain in the views you've already done in the right upper quadrant and the left upper quadrant. The problem is that when they've looked at misses on FAST exams, the reason people miss hemothorax is they forget to look, because they're so worried about the abdomen, they forget to think about the lungs. So in the lower left corner there of the images, you'll see the diaphragm, and above that is the lungs. And what we look for is we look for loss in the mirror artifact. So this image on the left, it has a mirror artifact of that liver above the diaphragm. Now, loss of the mirror artifact isn't always the easiest concept to understand. So another way to think about this is if you have fluid there in the lung, then then the ultrasound waves are still going to transmit. So if there's air there, then they're all going to be reflected. That's why you get that mirror artifact. But if there's fluid there, the ultrasound waves are going to continue to go through it and bounce off structures that are behind the lung tissue, which is the spine or the back. And so we can actually see in this image on the right where there is a hemothorax, we can see that spine there. And that's called the sonographic spine sign. So again, here there's the mirror artifact and there's that sonographic spine sign. So if you see that sonographic spine sign, you should be concerned for a hemothorax. Ultrasound is much more sensitive than X-ray. You need about 200 cc's of blood before you reliably detect a pleural effusion or hemothorax on X-ray. You need about 20 cc's for ultrasound. Okay, moving on to hemopericardium. You can assess this when you do the subxiphoid view, as shown in this lower video here. Alternatively, if the patient has a lot of bowel gas or has a protuberant abdomen, an alternative view is the peristernal long axis view, and that's literally where you take the probe and put it just adjacent to the sternum in that second to fourth intercostal space. I'm not sure why the clip's not playing here, but either one can let you evaluate an effusion pretty nicely. Here is some other, there's playing. Here is an example on the top row here of what a normal and a hemopericardium looks like in subxiphoid versus the peristernal view. When you're doing that subxiphoid view, one tip to improve your image quality is have the patient take a deep breath in. That'll bring the diaphragm down towards the probe and may help you get a better view. In the peristernal view, again, it's just sliding up and down in those rib spaces. You can improve your image quality if you have the patient turn on their left side, but that can be hard to do in the trauma patient. But try both views if you know, so you get comfortable with both. Moving on into pneumothorax. So here we are scanning anteriorly with the probe oriented towards the patient's head. And we're identifying the ribs, as we can see, as that kind of shadowing structure on the image left here. And then this hyperechoic pleural line where we see the apposition, the visceral and parietal pleura. And below that, we're seeing air, whether that's normal lung with alveoli, or that's actually air that is free air in between the pleura from a pneumothorax. It's going to look similar. The thing that's going to distinguish this is whether we see something called sliding. So we'll take a look at what that looks like. So here we have a patient with a right-sided pneumothorax, and we're just going to zoom in here and show what it looks like when we place the probe on the normal side. Here we see that hyperechoic pleural line, and you look carefully, you can see there's movement across that pleural line, and that's the normal sliding. When we scan the pathologic side, it looks very similar, except we see that pleural line and the reverberation artifact below it, but we don't see that sliding. We don't see those little comet tail, which are those vertical lines coming off of the pleural line. Again, here's an example, sliding. Other things that sometimes we see with the normal lung is we'll see these little comet tails. Those are little like vertical reverberation lines you're seeing, and we don't see those with the loss of sliding. You can use M mode to help you with this. And so what M mode does is it takes one line and it plots it over time. And anything that's in motion is going to look fuzzy, and anything that's not in motion is just going to look like a straight line. So here we see at the pleural line in the image below, we see like kind of like a 2 centimeters down, we see that fuzziness kind of going on, and that's normal. So that's what we call the seashore sign, and that's what you want to see. If there's no movement of the lung tissue, then you're going to have straight lines all across, and that's called the barcode sign. All right, so for pneumothorax ultrasound sensitivity varies based on the gold standard and the training of the providers, and whether it was done, actually an emergency department setting versus a trauma setting. And so it's actually kind of ranged anywhere from 49 to 98% based on what study you look at. The specificity is very high, 95 to 100%. And pretty much just no matter which study you looked at, the ultrasound sensitivity is almost always twice that of the chest X-ray findings, and that's for that same patient population. So pretty valuable. All right, so those are the 4 questions. How do we use it? Again, it's all about the patient's status. If the patient's stable, even with a positive FAST exam, we're probably still going to go on to CAT scan. And if it's a negative study in the stable patient, then you're going to clinically correlate. And if it's a high index of suspicion or a high pretest probability, which if you're already in the trauma bay, you're already kind of deemed to have that pretest probability. Usually you're still going to go on a CAT scan. But in other scenarios, you may clinically correlate. If you have, maybe the pregnant patient or the pediatric patient who you may want to try to withhold radiation, you may think about that differently. In the unstable patient, if it's positive, we're going to the OR, we're placing a chest tube, maybe we're calling for CT surgery for some kind of pericardial intervention. If it's negative in the unstable patient, then you may want to consider still doing serial EFAS exams while you search for another cause, and just kind of clinically correlate the picture. So let's jump into some cases real quick. All right, in this case, first case, there's a 40-year-old male who's involved in an MVC, screaming obscenities. He's got a fruity odor on his breath. And that's not because he's in DKA, it's because he's been chugging 4 Loco, his abdomen's distended, his blood pressure 74/40, and his heart rate's in the 130s. All right, so we always start off with an easy case. So hopefully this is jumping out quickly to you that you can see right here. Sorry, I didn't mean to, thought it was going to highlight it. But right here, we see the free fluid here in Morrison's pouch, the kind of classic location. Case 2 is a 25-year-old male, abdomen tender, stable vital signs. So what's the management here? So again, we see what looks like free fluid all right here, but in this case, the patient's stable, so you're going to go on a CAT scan. Case 3 is a 60-year-old female who fell down the stairs and has unstable vital signs. And what's the management here? So you might look at this at first and think you don't see anything. And hopefully in this auditorium, the lighting's okay. Sometimes the images don't show up as well. But if you look carefully right at that inferior pole of the kidney, almost the caudal edge of the liver, we see a little small area of free fluid. So, if you position this patient differently, maybe did head down, then you might increase your sensitivity. But this patient should probably be going to the operating room. Case 4 is a 35-year-old male who is in a hang gliding accident, unstable vital signs, and what's the management here? So here we're seeing, I don't really see a lot of fluid maybe in between the kidney there, but if we look right here, you're seeing some fluid in the subphrenic space. And so, that is concerning for free fluid. Unusual that it would collect here, but a place we got to always make sure we see, because sometimes the fluid does weird things. People have different anatomy. And so this would be a positive FAST exam. A 50-year-old male who was in an altercation presenting with right-sided rib pain, and the patient's hypoxic. So here, again, we're looking at the right upper quadrant, and we don't see any fluid in the subphrenic. We're not really seeing Morrison's pouch here, but what we are seeing is above the diaphragm, we see it looks like kind of anechoic, and we see that spine back there. So that's a positive sonographic spine sign, and the patient, might need to get a chest tube. A 36-year-old female who fell when the bus stopped. She looks well, and she's talking on her cell phone. So here's her ultrasound. So scanning through here. If I was there in person, typically I would poll people, how many people think this is a positive FAST exam? And a lot of people would think this is a positive FAST exam, but this is actually not. This is that black area you saw, that anechoic area, is actually the gallbladder. And so it's a little bit of it can be tricky with the gallbladder, but there's a few things that helps you make sure you don't accidentally identify the gallbladder as free fluid. If you notice here, we start off on Morrison's pouch, and we're actually scanning away from it when we see that fluid, which is an atypical location for free fluid. Additionally, physiologic fluid has rounded edges, whereas free fluid has sharp and pointy edges. So here in this image, we actually see side-by-side free fluid with the physiologic fluid or the bile from the gallbladder. And the gallbladder fluid has a wall around it. You kind of see this hyperechoic wall. If we go back to this case, you actually, if you look carefully, you see that there's actually a wall going around this fluid here. It's either kind of a hypoechoic hyperechoic kind of wall going around that area. So another indicator that's the gallbladder. All right, here's a 22-year-old male who fell onto a railing while skateboarding, has stable vital signs. All right, this is when you kind of look at Morrison's pouch here again. And it might be hard to see, but again, this is one of those caudal edge of the livers. You really got to look at that because that's where subtle free fluid can develop. Here's a 57-year-old obese male who fell from standing and has stable vital signs. So when you look at this, it kind of doesn't look like free fluid, but it definitely looks like there's something going on in between the liver and the kidney there. And so this is actually an example of a renal fat pad. So be careful of renal fat pads. They can kind of be a fake out for free fluid. They may be a little bit more iso or hyperechoic, but sometimes they do look hypoechoic. So it's just something to be aware of. They oftentimes will be bilateral and kind of correlate with the patient habitus. And one thing they won't do is they won't change in size with serial examination like hemoperitoneum would. So all things you can do to kind of tease that out. All right, case 9 is a 65-year-old male stabbed to the upper abdomen. All right, this is blood pressure of 82 to 30/34. So hopefully this is just to show example of hemopericardium. We actually see what looks like almost in kind of a serpiginous look to the RV here. So it looks like it's got tamponade physiology. So somebody that you'd want to get into a procedural or operative setting as soon as possible. There's free fluid there. There's actually some free fluid back there too. All right, a 17-year-old female who was beat up by her quote unquote friends, stable vital signs, but she's refusing to lay flat. So she's kind of sitting upright. And since she's sitting upright, you might think to yourself, where's going to be the most sensitive location for free fluid? And so, because what we already discussed with Trendelenburg positioning here, the pelvis is probably going to be more sensitive if she's sitting upright. The free fluid is going to go down there. And indeed, you ultrasound, and right there is a subtle amount of anechoic fluid right behind the bladder right there with kind of pointy edges. So that would be another positive fast exam. All right, and for this final case, we have a 34-year-old male who is in a rollover MVC and has tenderness over the right chest. The blood pressure is 75/35. And you do this EFAS exam, and here's what you see on the right side of the lung, or in the right lung. We see the pleural line, and it looks like there's sliding at times, but then it looks like there's not sliding. And so this is something you may come across. This is called the lung point or the leading edge sign. And what we're seeing here is we're seeing that leading edge of the pneumothorax. And so here we see the normal lung come into view and then it goes away as the patient breathes. So to get a little better understanding of what's going on here, again, when we scan normal lung tissue, we see sliding, as we see in this image. When we scan pneumothorax, we see this appearance where there's no sliding. And if we happen to catch that leading edge, then we'll see sometimes when the patient breathes in that the lung tissue comes into view of the ultrasound. And when the patient breathes out, it goes away. All right, so in summary here, the EFAS exam provides us immediate real-time diagnosis of hemoperineum and shortened times to the OR in unstable patients. Just remember to look at the caudal edge of the liver or Morrison's pouch for the most sensitive location. Think about positioning. And always remember the hemoperineum for ultrasound is a rule-in test for this diagnosis. So never feel bad that you may miss a small amount of free fluid. The patient's often going to get a CAT scan anyway. So and don't be afraid to call your exam limited. A lot of times they are in the trauma setting, and you don't need to worry about being perfect with ultrasound. The important thing is to do the ultrasound. EFAS outperforms chest X-ray for diagnosis of hemothorax and pneumothorax. So use it for those conditions, and it can immediately identify hemopericardium and tamponade. And so, something to, I didn't have time to talk about, but, another thing that has been evolving over the last decade is the use of contrast, which can actually improve the sensitivity of the FAST exam to actually the upper 90s, even in the early traumatic setting, and it's being done in a number of centers. So it's something for us to consider doing. I'm not going to go into detail about it here, but just mention it as something to think about for the future. Okay, that's all I have. Any questions? If please direct them to Dr. Rodriguez. Thank you.